think it's very important, and I think around the world where the groups that are doing data linkage and analysing linked data and making it available for a whole range of research do have that public benefit front and centre.
Yeah.
And I think everybody understands that it's vital to ensure that the ongoing dialogue, so the community, as these things evolve and develop, the community comes along for that journey.
Yeah. I think certainly when it's administrative data, I think it's healthy if a state or jurisdiction or even a country has some sort of social contract with the consumers of healthcare, particularly if that's publicly funded healthcare system as opposed to a private healthcare system, because then I think it's possible to create an understanding between the state and the public that actually one of the things that will happen, that their data are anonymised and privacy protected and will be used for research and a bunch of similar processes and there's a rationale because the benefits will come back to them and their offspring and their in the future, and therefore it's kind of part of an understanding, a compact between the state and the public. I don't think it's always there. And I'm interested to know if that compact you believe exists in Australia and within the states and the provinces. I think that is in the UK. I think we work very hard in our little corner of the UK to develop that compact, and we're just going through a process with the Welsh Government which will institutionalise that into policy. I think in other parts of the UK, not going to name names, but there are others where that compact has been undermined a bit by some less than perfect circumstances in the past, and confused by the operationalisation of things like patient opt-out of various different types of data sharing activities. And that makes a much more complicated environment in which to do the sort of work that we do, the data linkage, where patients are opting in and out of all sorts of different things in different circumstances. It's ethically sound. Why shouldn't patients be able to opt out of various things? There's nothing wrong with it. It's very mechanically difficult and expensive to operationalise. Personally, my preference is for that social contract to be strong, and then the state and its agents that do important work, the research community, to be completely transparent and how they do things, and to be regularised to the point where it's not loads of people doing weird and wonderful different things, that people can get their head around how things are done and feel comfortable with it.
Well, like many things, I think the idea of opting out is a balance, and it's really a balance between people's rights to opt out and the benefit when people don't. And particularly, I'm thinking that for often the most vulnerable groups may not be contactable, much less make an informed decision to opt in or opt out. So that if you do work on a project from an opt-in basis or an opt-out basis, and there's sort of tension there, should people opt in or could they opt out? And there's schools of thought about both ways of thinking. But I guess the benefit of being able to do things at a population level is particularly around those vulnerable populations. And obviously, we have recent immigrants to this country. We have people who are from disadvantaged backgrounds. We have Indigenous Australian, Torres Strait Islander people. So these are all different groups that may not be in a position to be effectively or easily contacted, and to give them an opportunity to opt in or opt out. And in moving to a situation where there isn't an opt-out arrangement, then I think it is that balance. It's finding that fine line of that balance where independent people can form a view that this work is in the public interest.
Yeah.
And that, I think, perhaps helps to mitigate the situation where you haven't been able to ask somebody whether they're going to opt in or opt out.
And one of the reflections, I think, on the execution of an opt-out in England, in some limited degrees about this space, is that it is highly susceptible to campaigns, from outside the health system, to try and influence individuals' behaviour based on sometimes completely inappropriate understanding of how things work. And I worry about the future where the opt-out mechanism could essentially be used as a football or a lever to make things happen. And I think that would be a shame, because the science suffers when you get large fractions of the population, particularly if those populations are the ones that really need the research most. So that makes me worry, and it kind of makes me think a little bit about sort of immunisation, where people can opt out by not taking their children to get immunised, but we know that if they do that at sufficient scale, everybody becomes compromised, because the whole immunisation regime breaks down unless a certain proportion of the population are quite a high percentage. So it's a kind of similar thing here, isn't it? That we really ideally want to be able to convince people that it's not in just your own interest you are thinking here. Your data helps the whole, everybody, not just, the decision that you make, yes or no, actually has an implication for society more generally. And I think we have our role in trying to help that argument a little bit. I'm not suggesting we all get on Twitter and start having bum fights in that sort of audience, but I think there is helping our policymaking colleagues and to try and think through the consequences of some of these decisions. It is important.
Well, having said that, I think probably we should just clarify that in Australia, not everything happens on that population basis. So in some cases, of course, there is informed consent and opt-in. Oh. So, for example, if we're using linked data in a clinical trial situation, then it's relatively easy to ask the person, you've consented to taking this medication or doing something else, and are you happy for your results to be linked into the population data? So there we do have consent. And certainly with consent, the approval process is much simpler, because people's person's been informed and they've agreed. And so some of our projects do have informed consent, but obviously then the broader population-wise data reviews, analysis, it's really not practical.
That's
particularly when some of them go back for 30 years and so perhaps the key people are no longer alive. So the opportunity to be able to do something without individual informed consent is very valuable.
Yes.
And hopefully the research that we've both been doing demonstrates the benefit.
Yeah, absolutely. That's a very important distinction, that where opportunities to opt out, particularly programs which essentially are interventional in some way, or that opt-out should be given. But I suppose I was more thinking about, as you said, as a kind of routine just delivery of healthcare, where I suppose we would make an argument that we work really hard in our centres to essentially render that data no longer personal data. It isn't really the data of those individuals by the time we've finished doing our job. It's just signals that our research colleagues can use to answer important questions, and that, in an ideal world, I think would be understood by populations and realise this is not in any way threatening to them. It doesn't come back to them in any way, and it's just a sort of routine practice. Now, I think this is still an active debate in lots of jurisdictions around the world. I think there's lots of, because I think you can see an ethical point in both directions. Should a patient or a person be asked every time their data is used in any form for any purpose? That's nothing wrong with that as a philosophical point of view. Or should the state be able, and its agencies be able to use carefully de-identified, privacy protected data for all public benefit opportunities? Well, they're both good, aren't they? But they're not terribly well. They don't really mesh very well. So I think there's a lot of discussions as I, like you, work with people internationally in this area. I don't think we've really got to the bottom of it, and it's more complicated again, I think, when we're talking about parts of the world where they either have a totally privatised healthcare delivery system, or a combination. Yes. Then it gets even more complicated, I think. In Australia, it's principally publicly.
No, in fact, Australia is quite different from other places, some of the other places where linkage is happening, because we have got a significant private sector. So around about 40% of hospital separations are from private hospitals, and we have strong private health insurance. And so we have not only a federated system, but on top of that we have a mixed system. But generally speaking, it's possible to navigate all of that and bring that data together. I think the idea of the social licence involving the community is really a journey, and I think that journey will go on as the data continues to evolve. Then those conversations need to continue to develop and evolve. And I think that probably the only answer is to keep having those conversations. I don't think there's a simple solution in the same way as there's not a simple solution to security of data. And certainly in Australia, we're currently sort of examining and exploring the 5 Safes framework. It is a framework that says it's not just about a safe system, it's safe people, safe projects, safe outputs, and those things all need to be considered to ensure the data is safe. And I think that's probably the bottom line for the social contract, so that people can understand that their data has been used for something that will benefit them and their families, but the risk to their personal information is really, can be managed to a level which it's virtually negligible.
Yeah.